The next one we're going to have is Jason Lesandrini, who's going to talk to us about ethics in the ICU and particularly how that revolves around do not resuscitate and some of the terminology around that.
Thank you, Dr. Martin. All right, we're going to get started. So today we are going to talk about the criteria for what's called a DNR candidate, discuss potential improvements in this process, and then I'm going to give you some data on a study that I did with some colleagues at Grady. But I do need to say and caveat that I'm no longer with Grady anymore. I've moved on to Wellstar. So this is Grady's data, but research I did when I was there. All right, so let's start off. Mr. Smith, a 75-year-old man who presents to the hospital after being found down under a local bridge. He's admitted to the ICU in septic shock, was intubated in the ED for respiratory distress. By hospital day 5, there's no improvement in his mental status. He has a massive GI bleed from some unknown source, and they consult surgery and determine that he is not, surgery says that he's not a surgical candidate. He's placed on multiple pressors with presumed imminent death. They looked, at this time, they finally got to really thoroughly review his medical record and noted a diagnosis of metastatic lung cancer that had spread to his brain, liver, and bones. So the question the team was discussing at the time was, can we change his code status? So I'm interested in what you all would do in a situation of Mr. Smith. What would happen? Would you change his code status and just change it? Would you call somebody? Would you just leave it be? What would you do? Could you find family? Right, so that's probably one of the next steps. Could you find any family? And assume you could or couldn't. What would be how would the decision tree go? Let's say you could find them. What would you do? What would you say to them? Futile, not fixable. Okay, comfort care. All right, assume you couldn't find any family. What would you do? Same. Futile, but then would you change the patient's code status? No, yes? No. So interestingly enough, Mr. Smith has no family that had appeared or been located. They documented in his record that an extensive search had been done, and now the attending is claiming that the patient will die within the next few days no matter what's sort of done. So what I'm here mostly to talk about is a case just like Mr. Smith, but happens all the time, I think, in ICUs across, well, let's say this, Georgia, definitely in the Atlanta region. And what I'm going to show you is data on patients where it happened with patients at Grady. So lo and behold, Georgia is, I guess you could say, fortunate enough to have developed a state law that looks at code status for patients who meet Mr. Smith's criteria. And they call them DNR candidates. Okay? So the law says, an attending physician may issue a DNR order if no person is available or competent to make a decision and all the following criteria are fulfilled. So 1, there's written documentation by a second physician that the patient is a candidate for DNR. We're going to talk about what that means. An ethics committee concurs in the opinion with both the physicians that the patient is a candidate for DNR, and the patient is receiving inpatient or outpatient treatment from or is a resident of a healthcare facility other than a hospice or a home health agency. Sorry, I forgot my notes. So, a couple quick notes. I wanted to say that the third point is particularly important for surrogate patients who get transferred to a hospice. If you don't have a decision maker, in essence, you'll have to, what the law basically tells you is that you have to actually make them DNR before they go to an inpatient hospice setting or a hospice setting, because you can't physically do this process while they're in hospice. And then more often than not, we know that a lot of hospice facilities in the local Atlanta area don't actually have ethics committees, and so they can't convene these panels. Excuse me. Okay, sorry about that, I apologize. So what is a candidate for do not resuscitate? It's based on the determination of a reasonable degree of medical certainty by an attending physician with the concurrence of another physician that a patient has one or meets one of the following criteria. So they have a medical condition which can reasonably be expected to result in the imminent death of the patient, or is in a non-cognitive state with no reasonable possibility of regaining cognitive functions, or is a person for whom CPR would be medically futile. All right, so let me tell you a little bit about what that means. So the first one, what it's generally, I mean, it's pretty self-explanatory. I think some people do have some questions and concerns about what it means to be in near imminent death, but I'll let you all figure that out. The second one is in a non-cognitive state, not likely to regain cognitive function. When I ask most people around the state what they think that means, especially some of the lawyers, they think of people like Terry Schiavo. That's the example they give me. And then a person whose CPR would be medically futile, the code section actually specifies what medically futile means, right? Which is up for debate and discussion. But they say that CPR is medically futile when CPR won't work or it'll only work temporarily such that you'll have to keep doing it over and over again. That's what futile means for the state of Georgia. Now, in 2012, they amended this legislation and added, or otherwise medically futile. What that means, no, and they did not define, they just said, or otherwise medically futile. So I think it's left up to the clinical team to make a determination that it would be otherwise medically futile and document that in the medical record. So we looked at all the patients at Grady that this scenario happened and compared them to some benchmark data that was out there about when DNR orders actually get issued for patients, when patients make DNR decisions themselves, when they make them with their loved ones, or when just the loved ones alone make them. There's no data out there that talks about, that's captured what we'll call surrogate lists or unbefriended patients and when DNR orders get captured. This is the first data set, I think, yet to be captured and soon to be published. So the study that we looked at was Torque's study. That was a retrospective review. It looked at 683 inpatients from 2004 to 2006 in a large urban public hospital. It was in Indiana. Their adults in their study were all 65 or older, and it was between a 3-year sort of period. They looked at the frequency of surrogate decision-making for DNR orders specifically, and then the timing of those orders. So how often did they actually happen and the timing of those orders. And this is what they found. They showed that when surrogates make the decision for a DNR order, the mean time from admission is 6.6 days. Statistically significant when compared to when patients are making them, roughly odds ratio of 1.98. And the median time from DNR to death is basically about 1 day for when a surrogate makes the decision for DNR orders. When a patient makes the decision, it's about 3.2 days, and the mean time for death from DNR order is 3.5 days, and the mean time from admission was 4.4. So this is the data we compared our study against. So that when a DNR order is acquired in a surrogate, it's statistically longer than either when it be the patient or shared decision making. So we looked at what are the characteristics of DNR candidates, sort of at a large urban academic medical center. And we did a retrospective review of ethics consults for surrogateless patients from 2001 to 2011. We were able to identify, I think it was 137 cases, worth only 87 of them meeting the criteria with sufficient information to actually capture. What's important to note, 69% of them were male, 57% of them were African American, and this is consistent with demographic data in large urban public academic medical centers. What's interesting about some of the data is that you can see that the majority of the patients that we looked at were all over the age of 50. It's about 80-some%. And then we had some really sort of interesting data when it came to what the time from admission based on discharge status. So the overwhelming majority of them in our case died, but there wasn't really anything particularly statistically significant. But I think what's interesting to see is that once the consult, so the time when the DNR order happens is when technically the ethics consult happens, the time to DNR to discharge in days actually maps this sort of national data. Okay, so we have long stays in the beginning, and then we get shorter stays at the back end after the consult actually happens. The one that's worth pointing out is time from admission was 0 when the patient was was home to get the DNR order, and that's because someone from the ER was proactive and got someone involved. So I think the key in this slide is that the length of time to get ethics involved in these surrogateless patients is actually pretty significant. what one of the folks on the study said, probably way too long, compared when the means and medians of the paper the TORC paper that I mentioned earlier. But after the DNR order gets in place, we have similar outcomes or similar discharge metrics. So the next time we looked at anything about particular admission diagnosis, there wasn't anything that was statistically significant in this, but I think it's worth seeing again that the time to actual capture of a DNR order or till an ethics consult is actually called in place is significantly higher than what the national data shows, but the time to discharge, it gets pretty close to what this comparison paper looked at. So the one big statistical significant finding we had was with homeless patients, which is not surprising because a lot of homeless patients, it's hard to find families for, right? So we showed that their time from admission to DNR was 34.5 days. It was significantly longer than the comparison. And then the other thing to say is that when the DNR order actually gets placed, we have, it matches, in essence, the national data. So after ethics gets involved, time to discharge matches national data. Excuse me. So again, not a lot of statistically significant findings, but I think interesting findings when you look at these criteria. So these are the three criteria for DNR candidacy, and we added multiple because in the process that we do, and I'll explain a little bit more about that, you could check, we have check boxes. At Grady, you have a checkbox, and some attendings check more than one box. It's just an or, and you only need to check one, but some of them check all three, some of them check two. So you can see the breakdown. The largest percentage of patients were those who were in a non-cognitive state, and they had roughly 16 days from time from admission to DNR. Okay, so this is sort of the crux of where we're at. I think it's interesting. One, it's the only data set that probably will be, so far, will be published on surrogatless patients and DNR decision making. But I think it's worthwhile to think about how you do this in your own facilities, right? This is a state, so for those of you who are in Georgia, this is a state law that recognizes you can actually, in fact, do this. But when I ask across the state, and even just in the Atlanta area, there isn't much capturing of these patients or this data. But we know when you do it, you actually mimic discharge times. You shorten you match the national data on discharge. But if you don't have the DNR order in place, you probably don't get that same outcome. All right? The patient may still die, but it depends on the number of days they may live and then be discharged. So one of the things that we're doing with the data, the next step in the data process is to actually identify some proactive steps where we can sort of mimic that one patient who got discharged home and start identifying these patients in the ER so that we can have shorter periods of time from admission to DNR order. I think the other, so the other interesting thing that we're going to start looking at is case controlling to see if this decision would actually be the same. So we can try and match the national data on patients who make their own DNR decisions or patients who have surrogates or shared decision making. We can try and match that data by proactively addressing it. But the question still remains, in this region of the country, would this DNR candidacy panel actually mimic the decision the patient would in fact make? So the next step, so the second step in the study that we're about to start now is to look at case controls for patients to see if DNR statuses were changed, at what time they were changed, and if they were actually made, or if patients actually keep the same code status. And then the other thing I think we need to start thinking about is from a state level. So a lot of these policies that involve ethics committees have oversight from a state level, or they have to capture the data and submit it. So the futility statute in the state of Texas is a number one example, is the big example, where you have cases that come in through the committee, they're supposed to be declared futile, those have to be reported out in some fashion. And so maybe we need to start thinking about that sort of from a state level and start tracking this data and look at it. And then we're also going to be doing some sort of intrastate discussion about this to see if other states around in the surrounding area are interested. That's it. That's the short and sweet. So I'll leave time for questions now, Dr. Martin, or after.